Welcome to today's Insta Live. My name is Andreia Trigo, and for those of you who don't know, I am a fertility nurse and coach, and I've been supporting patients who have been trying to conceive and who want to first identify whether they have a problem that is keeping them from getting pregnant, and secondly, connecting them with clinics that can help them achieve their dreams. And today I have a very special guest. It's Aina from Reproclinic in Spain, and Aina is an embryologist, and she's going to tell us everything about assessing the quality of embryos. And so let me see if I can bring Aina to talk to us and tell us everything that we need about the role of the embryologist and what she does behind the lab and how does she decide which embryo she should choose in order to transfer to the uterus. And I think it's such an incredible topic because we usually are aware of the normal procedures. Oh, hi, Reproclinic. We are usually aware of the procedures that happen to us as patients and having our eggs collected, having the sperm collected. But what happens behind the scenes once you have those embryos, and how do you assess their quality? How do you know that they are good to transfer to the uterus? So let's bring Aina to today's conversation. I'm super curious. I'm trying to accept. I don't know why this isn't working. Let me see. Let's try again. Oh, hi.
Hi.
Technology.
Hi, how are you? Hi.
How are you doing?
Good, really good. How are you?
I'm okay. It's so good to talk to you today and to give our listeners an overview of what happens in the lab, because it's that area that patients don't have access to. So it's a bit mysterious what is happening there. So thank you so much for joining us.
It's a pleasure. It's a pleasure.
And Aina, can you start by telling us a bit about your role as an embryologist? What has made you choose embryology as a profession, and what do you do in your day-to-day?
Oh.
It's a deep question.
Yeah, I studied biotechnology, and I remember when I chose my degree, I chose it because I really like genetics and reproduction and that stuff, but I didn't want to do actually only genetics. So I studied biotechnology, and while I was doing it, I kind of forgot about genetics and everything because it has lots of things inside biotechnology. And in my last year, I did a subject that it was kind of assisted reproduction. It was just the subject. And then I was like, oh, that was it. That was why I studied this and why I did all this whole degree. And then I just did a master's about assisted reproduction medicine. And then here.
You fell in love with assisted reproduction because embryologists play such a key role in fertility treatment. Tell us a bit about what you do once the woman gives you the eggs, the man gives you the sperm. What do you do with it? And I bet it's a million things, but...
Yes, I was like, what we do? First of all, it's we don't kind of start when we receive the eggs. It's the day before. You need to prepare everything because you will put those eggs and that sperm somewhere, and all the media needs to do in a certain pH, in a certain temperature and everything. So you need to prepare the dishes for that. So in the dishes, it's
like a petri dish, like we usually remember from our high school lab classes. So it's like a petri dish.
Exactly. You can there's different kinds, different styles, but kind of for a summarize, that's it. And then the day before, you need to check what are you going to do the next day, what's going to happen. You always need to check like the whole story of that patient. Like it's
Okay.
not the same if it's, I don't know, an egg freezing or you're going to do a FIP or an ICSI, like it will change. Or if it's just a transfer or whatever, you will need different dishes for that. So the day before you need to prepare everything. And obviously it's not the same if you need to know what to expect of that patient also. Like how was all the preparation, if they have lots of follicles or not, like you need to be ready for what you're going to do the next day. Then the next day, for example, in a IVF cycle, like kind of like the more
The
common
standard.
one.
Yeah.
Yeah, the standard one. Like the patient will come, it will be the egg collection. Then the doctor will just aspirate all the liquid that is inside the follicle, and then that liquid will it will, like they will place it in some tubes, and we need to check those tubes, and then it's like in the same moment the doctor is just doing it and you are just counting how many eggs are you finding.
Yes, because the eggs are not visible, so you need to look under the microscope to
Yes.
see the eggs, isn't it?
Yeah, but actually you can predict where the eggs are. Like you
Okay.
need, yeah, you you need to be trained on that. But anyway, eggs are quite shiny,
Okay.
so you can just see it like on the normal, like you can just see it, but then obviously you need to look at the microscope to check it.
And at
And
the same time, are you receiving the sperm, or maybe the sperm might
no,
already be frozen?
either the sperm is frozen and then it is still frozen, or if it's like the man will produce that day, it will be later on the day.
Okay.
It will be later on the day. And then, for example, if we do an egg collection at 9, normally the man will produce around 12 ish,
Okay.
because we will need to inject around between 4 and 5 hours after egg collection.
And
So we want the sperm just to be like 1 hour before.
so you're receiving
Yeah,
those eggs, and you're telling the doctor and the team in
exactly.
theaters how many eggs you have in those little
Exactly.
tubes.
Exactly. And then they know like how is it going, and kind of like if it's going well or not, or if you're finding what they are expecting or not, because obviously you also see the ecography, so you know and kind of predict what kind of happens. After that, we kind like the egg, if you imagine it, like it's a bit stupid, but if you imagine it, it's like a fried egg.
It's like a
So
fried egg.
exactly, you will have the proper egg, and then it's surrounded by lots of cells. That's the cumulus. That's what actually you can see it.
Okay.
Why you can see it, because all those cumulus is quite shiny, and it can be big.
Okay.
All right. So we kind of cut the cumulus that surround the egg and just try to make it as small as we can, because if there's blood there, it can be quite toxic for the proper egg.
Okay.
So it's you kind of try to make it like to clean it as much as you can. All
Okay.
right. Then you will do that to every single egg, and then you will keep them for some hours. All right. After that, you will receive the sperm. And when you receive the sperm, you need to process the sample. All right. When you process the sample, what we do is you just check, and you kind of check like the basic parameters like on top of it. And then you first of all do a gradient. That means that it's like two different medias that you put over there, and they have like when well they have different densities, and it's quite harder for the sperm to swim.
Okay.
So first of all you put one that it has like lower density, and then you put the other one, so the sperm that will be able to actually swim
It's strong.
by then it's a stronger one. All
Okay.
right.
So you're
So
testing them.
exactly. So first of all, you do that in order to try to to get the best ones, and all the ones that cannot move or they are not swimming, they won't go through it.
Yes.
So that's like the first big part. And then after that, you just remove the gradients and just pick the pellet. That's where the ones that will like had swim, they would be there. And then you just wash that. That's the part of the sperm. All right. Obviously, it always changes on the sample. There's samples with like lots of concentration and samples that they don't have. So you will just kind of adapt a little bit, like the gradient, if you have more or less, and try to always have kind of the same concentration to do the ICSI. Because if you have lots, then it's quite hard to choose which one to get because they are all swimming over there. And then if you do kind of like you are stronger there and quite sharper there, then you will have less, but they will be better. So it's easier to choose them.
But if a sperm is strong, does that mean that the embryo will be of better quality when you get to fertilize the egg, or not necessarily?
It should.
It should, yeah. Okay, fingers crossed.
It's like you need to have like nice sperm and nice eggs, but then you can also have a nice embryo, and then you need to check also the genetics of it, because you can have really nice embryos, and if they don't have like good genetics and they are not euploid, it's
the genetics are not always checked, aren't they? I mean, the genetics of the sperm and the egg, we can't even do it. Yeah.
No. You can check the genetics of the embryo, but you can do a test on the sperm, but you will not be able to check the genetics of the sperm before doing the ICSI. It's just like a test. Okay. But you can check the embryo, not the sperm.
So you have sperm and you have egg, and then what happens next?
Okay, what happens next is you need to strip those eggs, all right? When you strip the eggs, like, as I told you, I cut them. So you try to make it as clean as you can and to put it on that media. But after that, you need to remove all those cells. You, like the eggs, in terms to be injected, they need to be mature. Okay. All right? Not all the eggs are mature.
Yeah.
They can be, if they are mature, they are what's called M2, but they can be M1, or they can be VGs, or they can be just a normal and you cannot do anything with them. To check if they are mature or not, what you need to do is you need to remove all those cells, and then you will see.
Okay.
All right. So to remove those cells, you have strippers. All right. Strippers, it's like a pipette, all right? And you have like capillaries with different diameters. So you will just pass the eggs first, the one that has like bigger diameter, and you will just remove some cells, and then to the other one, and then you keep doing this until you have like the egg stripped, kind of, and you can check if it's mature or not. When you check it, it has a polar body, so it will be just the egg, and then on the top it has like what's called the polar body, that is like a little pump on it, and then you know that it's M2. Okay. So those ones that are M2, then you can inject those ones.
Okay. And by inject, you mean you're going to put the sperm inside the egg? Or yes. Are you just going to let them naturally find each other? There's
two types of fertilization. Either you do conventional IVF or you do ICSI. If you do conventional IVF, you don't need to strip the eggs. So you will just put the eggs and the sperm together, and then you wait until next day. And if you do ICSI, it's when you need to strip the eggs, check which ones are mature, and then inject that sperm to the egg.
Okay, perfect. So now that the sperm is inside the egg, I imagine the genetic material needs to connect inside, isn't it, to become one and start growing.
You cannot know that. Like when you inject it, you see that you're leaving the sperm inside because you can see it, but it's not momentaneously. So until the next day, you don't know if it has fertilized or not.
So we need to wait a few days to see how it
Just
develops.
the next day, you know if they fertilize or not. Just the next morning, you will know if it has fertilized or not, and you can see what's called PN. That is you can see the egg, and inside you see like two circles, kind of, and one it's from the genetic material of the egg, and the other one is from the sperm. So then you know it's fertilized, because it can also fertilize wrong. So imagine if it has 3 PNs, then something is wrong over there because it has much more material than it should. So you need to discard them. Or if it has only one. So it's just the only ones that has 2 that you know that they fertilize properly. They need to have like 2 of those PNs, that is like pronucleus, and then 2 polar bodies.
So it's almost like you're always checking every step of the way if things fall within the norm, if they are okay, every step of the way.
Yeah, because the fertilization, you will just see it the next day. Those PNs, that's called pronucleus, it will disappear at some, like, it disappear at like in some hours, and then it just disappear. So you just need to check them on that time, because if not, the embryo will divide, and maybe if it has not fertilized, kind of nothing will happen because the egg won't divide, and kind of that's it. But if it has fertilized wrong, the embryo may divide.
Yeah.
And then it may end it in a nice blastocyst. So you need to check at that moment if it's actually like a normal fertilization or not, because if not, it can be tricky.
Yeah.
And obviously, you need to inform the patient. The patient is like really stressed about it. It's a really moment that they need to know it at that point.
That's what I was going to say. Patients also want to know, don't they, how many eggs have fertilized.
Exactly. That's quite important.
And then from that day until the day of transfer, the embryo is there dividing itself and growing.
Yes.
And you keep monitoring them and checking on them to see if they are normal, or how do you assess embryo quality at that point?
It actually depends on the laboratory. Some labs, they just check it every day. We do not. We just check it on day 5. That's what we expect them to be at blastocyst stage. They can get into blastocyst stage at day 5 or day 6. Like the actual process is that at day 1, we would see if they have fertilized or not, but it's still one cell. All right, you can just see the 2 pronucleus, but that's all you can see. Then at day 2, they start dividing, and you expect them to be around 4 cells, kind of. They can be like 2, 4, 6, but you would expect them to be 4. If they are 2, they are a bit slowly, and if they are like 6, they are a bit fast. Then at day 3, they will just continue dividing. You expect them to be around 8 cells. And then at day 4, they're what's called a morula. It's like they continue dividing, but the cells start compacting one into the other one. So it's just like you can just find a mass of cells that start compacting. It's when the embryos start to organize themselves. At day 4, you cannot really have lots of information about it, because it's like when they are organizing, so you cannot see anything over there. You just kind of see a mass. It's like day 2 and day 3, you can count cells and you can be like, oh, there's 9, there's 8, there's 10. But at day 4, normally they start to compact, so you cannot see that much. And then it's at day 5 when you expect them to be in the blastocyst stage. I think that's the more critical point of everything. And it's when the cells are organized. So at that point, the embryo knows what's going to be the placenta, what's going to be the proper fetus, and which cells are going to do everything. Wow. So that's the important bit, because even you can have a really high fertilization rate, but if you don't achieve blastocyst, like there's nothing
There's a
Like
problem.
the important bit is the blastocyst and the quality of the blastocyst because it's what you're going to transfer.
And
If you
an embryo that survives up to that point has much higher chances of surviving as well. That's probably why you say you check them on day 5, but you're not checking them every day.
Exactly. We just check them on the 5 because at the end, if they get into day 5, and it's also where you can have much more information about them, and when you can like classify them much better.
Mm-hmm.
At day 3 or 2, you just know if they are dividing or not. Okay,
Yeah.
you can know if they have the cells that you expect them to be. But if one of them has 5 cells, and then it's a really nice blastocyst, and it's 5 cells at day 2 instead of 4, it's a nice blastocyst anyway. So you're going to transfer that one.
Yeah.
Like you're not going to throw it or discard it. So that's it. The important bit is it's the blastocyst stage. That's where you can see what's the trophectoderm and what's the inner cell mass. It's where blastocyst you can just blast. I would say for you to imagine, kind of like a blastocyst is like that chocolate egg that has a toy on it inside.
Kinder egg.
Kinder egg. It's kind of that. All
Really?
right.
I love your analogies.
And then the chocolate part would be what's the trophectoderm, all right? And all those cells, it's what's going to be the placenta. And then the toy that will be attached to a part of it, it's what's the mass.
So
the
that
initial
will be the
mass.
baby.
Exactly.
That's
All right. So at that point, you will have much more information if it has fragmentation, if it has a huge mass or not, like if the trophectoderm has lots of cells or no, it has like poor quality and doesn't have that many cells. And then you expect them to get into blastocyst stage at day 5, but they can also get there at day 6. And also a part of what's like the inner cell mass and the trophectoderm, that you would qualify them between A, B, C, and D.
Yes.
And also you would qualify the expansion rate of the blastocyst. The blastocyst at the beginning, when you imagine the egg like something like just like this, then they start dividing and dividing, and they at day 4 they start compacting all the cells, and then they will have like surround that circle, that's the cells and the egg, they will have what's called the it has like a shell, it's like pellucid zona.
Yes.
All right, that gives protection to the egg during all that part and that process. And when it gets into blastocyst stage, the blastocyst needs to get bigger and bigger because all those cells are dividing. So if at day 3 you would have 4 cells and at day 5 you have a number of cells that you cannot even count, obviously they need space, so the embryo will start expanding. So the number that you give to the blastocyst is the rate of expansion. So if it's 1 or 2, it's really small and you cannot actually see the cavity between the inner cell mass and the trough. It's quite early. Then if it's 3, you can actually see what's the inner cell mass and what cells are going to be the trough. But that zona, it's quite thick still. When it's 4, you can there's a huge cavity and you can actually see inner cell mass, trough, and that zone it's really thin. And then when it's 5,
it ranges up to 5. You said.
Yes, well, up to 6 actually.
Okay,
when
6.
It's 5, and imagine if that shell you make like a hole and the embryo pop and start going out of that shell, that would be 5. And there's a moment when the embryo kind of pop out completely, and then it would be 6. But normally we don't see 6 in the lab. Okay. Normally you would transfer or freeze it before.
So when patients see a number, they would be able to understand how good it is from the development point of view, based on
Exactly.
1 to 6.
Yes. That number, it just means the rate of expansion of the embryo. It's not like regarding quality or
Oh,
anything.
so it's
It's,
just expand.
well, it's the expansion. Like quality would be if it's an AA, it will be really good. If it's an
Tell me,
AB, it will be.
yes, tell me the letters, because patients ask that all the time. So what do the letters mean? What are you looking at in order to give them those letters?
Normally in the blastocyst stage, you give like the quality, it's a number and two letters.
Okay.
All right. And then the first number is the rate of expansion. So if it's 3, it's a blastocyst, but the zona is still thick. If it's 4, the zona is thin. If it's 5, it has popped.
Okay.
Normally it's those 3. And then the letters, the first one refers to the inner cell mass, and then the second one refers to the trough. So if you have a 4AA, you have a expanded blastocyst, and both inner cell mass and trophectoderm are grade A, which is top quality.
Brilliant.
You can have one that is AB, that means inner cell mass is top quality, which is A, and tropho it's good, but it's not top quality. So maybe it doesn't have that many cells. It has a bit of less cells, but it's still good. It's a B.
And for you to decide, I mean, of course, you've had years of training for that, but are you sort of looking at what the perfect image should be? Or do you have like an image for what each letter should be? Or how do we decide between one or the other?
You kind of have a mental image, I would say. Normally, if I need, it's something that if there's 2 people in the lab, you will always check with the other one. Kind of like, do you agree with this? Do you agree not only with the letters, with the order of the embryos, you know?
Okay.
I think it's much more important which one you choose for transfer and which one, like in what order are you going to freeze them? Like this is the best one, like the order of quality, then actually if it's an A or AB or, you know, but you check like the compactation of the mass, how big is that mass in terms of the mass, if it has fragmentation or not. And then the tropho, it's more about how many cells it has and like kind of how it looks. If it has sometimes the tropho has like part that has lots of cells and some part that don't have that many. So then you would not put an A there because it doesn't have like cells everywhere. It has some parts that are really good and some parts that are not. So then you maybe would just choose a B for that. And then if it has really low cells and it has cells but not that many, you would just put a C.
So the letters range between A, B, and C, being A the best.
Yeah, and you can also have a D, but it's kind of like degenerate.
Very bad.
You would not freeze that, yeah. We don't freeze the CCs neither here or transfer.
Okay, so you would recommend the doctor, you tell, these are the ones we have, and these are the ones that I would recommend would be transferred first.
Exactly. You choose which one are you going to transfer and which one are you going to, when you freeze them, you know, in what order, like which is better than the other one. So which one are you going to transfer and which not?
And after you freeze, when you defreeze them, do they change at all, or the quality just sticks to whatever was before they were frozen?
Quality should stick.
Okay.
Quality, it can happen that then when you thaw them, the embryo won't survive. Like that's something that can happen.
Yeah.
It's not like I would say it's a really low percentage of that. Like that happen. But it can happen and people like patients need to be ready
Aware.
for that and aware. Yeah, it's not like, oh, it's something that I would not thought about that was an option. It's always an option that in a clinical procedure.
Yes, of course.
Like
but
nothing it's guaranteed 100%. That's it. But it's really low that won't happen.
The techniques these days, the freezing techniques are really good, aren't they? So it's like over
Exactly.
90% success.
Yeah.
Yeah.
The thing is that when you freeze and when you thaw, what you need to do is like you put the embryo in some media. What you're trying to do is just trying to remove all the water from the cells and putting a cryoprotector on
Yeah.
it to freeze them. Because if you, like, cells has lots of water, so if you freeze them, they will just create crystals,
Yeah.
and then it won't survive. So you need to put them on some cryoprotectors, and then that's what you do when you freeze. And then when you thaw, you just need to remove all that cryoprotector and be back to that water part. So what's quite normal is after thawing, the embryo will be a bit like more compact, and they need to expand slowly. So that's why normally we would just thaw 2 hours before the cryo transfer or before the cryo transfer to see like that embryo is actually reacting and expanding again. So I would say if an embryo is for AA, it would like it had been frozen, so
It would
you
be,
won't find much more cells on the tropha than the ones that you had.
yeah,
It,
exactly.
it would be really odd. The thing is that you maybe can find a part of the tropho that it has not survived that well to to the thawing or something like that. But normally, the quality is thick on that.
And I know you spend most of your time under the microscope looking, but it's such precise work. But it's work that can have such a big impact on patients' lives. What is
Yes.
the thing that you love the most about being an embryologist?
I think I really, because you say like I spend lots of time under the microscope, but also I spend lots of time like talking to patients
Okay.
and not also talking to like you have lots of papers to do and everything, but apart from that, you never have like the same day at work. It's just like you will have different patients with different stories. So you, it's not, oh, I'm freezing eggs and I don't know
The
who
patient.
they are, or you know, it's like I'm freezing an embryo. I know the patient because I met her and I've been talking to her like all these days, so I kind of know their story. I know if they had a miscarriage or not, and it's
So there
like
is a
you.
story behind the egg, the sperm, and the embryo that you are working with.
Exactly. Exactly. So I really love that you can, it's really rewarding kind of what you do because you know what they are being going through. It's not easy. You're there all, it's kind of a week actually, but it's really intense. So you are talking to them lots.
And
And
and Aina, have you ever been in a situation where you've seen that embryo and then a year later you've seen the baby that came from
yes,
that embryo?
that's lovely. That's really, really nice. That's lovely. That's one of the best things of our job, actually. Like, it's why I do that, you know?
Yes.
So,
Aina, thank you so much. I think you have explained in such big detail what an embryologist do. And I think it helped clarify because usually patients don't get to see that side of things. So it's so good that you've explained what happens to the embryo, what happens to the sperm, the egg, and all of that, and how do you actually assess them as well. So I think it's great that you have clarified all our questions.
it's
And
been a pleasure.
for anyone who is listening, we're going to leave this video on IGTV today. So if you've joined halfway through, you'll be able to watch it again. And if you have any questions, you can send us
Exactly.
a message to me or to Reproclinic as well. And I'm sure we're more than happy to help you
Exactly.
understand more about embryo assessment and quality. Aina, thank you so much for joining us.
Pleasure. Thank you to you. Bye.
Bye.